Next on the docket here is Dr. Fernandez. He is our physician in Rockville and Silver Spring. I'm very familiar with VenaSeal, so he's going to talk to us and demonstrate how he does VenaSeal.
Thank you, Dr. Soto. All right, so I think we're going to have a conversation about VenaSeal, but what we have is actually a video of me performing the procedure. We try to keep this as short as possible and try to hit in some of the key points that I find appropriate in performing this procedure. Obviously, there are a lot of variations to this, and as you get more experience with this technique, you would also find what works for you, your patients, and your practice overall. I find that is a fantastic a procedure to our armamentarium, how we manage venous disease. Really use it specifically for patients with disabilities, senior patients. The minimally invasive component of it is really nice. Lots of patients with lack of mobility, wheelchair bound, autistic patients that have had, this is the procedure of choice. Number one, again, one pinprick, minimally uncomfortable to the patient at that point, and after that, it's sort of a breeze. Great closure rate, great safety profile. So it's really nice to have that option for these patients, and they tolerate it very, very, very well. And also the recanalization being low compared to some of the other techniques in these patients is important, as you don't need to bring back. So let me see if this hopefully will work. And here we go. Okay, so we're going to be doing a VenaSeal procedure on the left great saphenous vein. We also have some microflebectomy associated with this procedure. I'm going to be walking you through this process step by step. Some of the things that I do differently, I will narrate. So we're going to be looking for since this is a non-thermal, non-tumescent technique, we can actually start pretty low in the calf and just need to identify the saphenous vein here. And we're going to be just giving a little bit of local anesthetic with 1% lidocaine. And it just gives a good wheel there. We have our axis needle, spinal needle, Cook needle, whichever one is your preference. And then the initial part of this is just much like a radio frequency, in which we are going to be introducing a 7 French introducer. So here comes the part in which if the vein is very straight, you can technically bypass, which is the wire. Find that saves some time if sometimes skipping the guide wire. And then you're going to be putting in your introducer. There's a dilator associated with it. Introducer has been flushed with saline. This is what they would refer to as the wet part of VenaSeal. Catheter with the glue is the dry part. So I just slide it in. This is probably about a 45 centimeter segment, so just about there. And then we can safely remove the wire. And then I'm confirming here sort of where I start seeing my sheath in relationship to the junction. I'm just about right because we still have that dilator in. So now I'm going to remove the dilator because I know that I don't need to go any further, approximately towards that junction, and cap it again. I like to, once again, just check my distance from the junction. This is actually important, and I'm nice and safe distance, at least 3 to 5 centimeters from that junction. Okay, here comes the actual glue part, and one of the things that already has been done here is that the syringe has been pre-filled ahead of time by my assistant and with Max Glue. I'm going to finish priming this tubing. One of the things that might be hard to see in camera is that, as I mentioned earlier, surgical assistant already had partially primed it, and there's the line as to where the glue is. You actually want to bring that glue to the most forward laser mark. So now this is properly primed. I'm going to remove syringe. And we're going to put this through our sheath here. This is the next important step. You're going to get to the second laser mark. This is another little gray mark here. And you're going to bring that just to the tip of the sheath. I have my assistant hold the 7 French sheath in place, and then I just hold this and I pull back just the blue sheath. What that does, what you're done is bring the glue delivery catheter to the tip of the blue sheath, and now you pull the sheath back and expose the tip of glue delivering catheter. So that tip should remain just where you left it. That's why pre-measuring that distance from the junction is important, because you're going to be just leaving that exactly the place. If you were not to just pull forward, all you're going to be doing is actually going forward with the catheter closer to the junction, which you want to avoid. And you see our catheter tip right there. Okay, I can see my junction for a little more proximally right there. So I get about a 3.5 centimeter screen wide. I always like to take a picture here, and I like to measure it. With the catheter, you see what they call the little star pattern. You start seeing towards the end of that catheter, and then you go beyond it. And I'm going to compress it with my probe, and now I'm going to start the actual injection. So I'm going to depress 1, and I go 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000. And I pull 1 centimeter back. And then I go again. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000. And I pull 3 centimeters back. And now she's going to be applying some pressure here. And we hold this for 3 minutes. This is critical here that we continue to hold pressure with the probe. That's the most critical part. Fully compressing that saphenous vein before the junction. That's really what's going to prevent that glue from migrating towards the junction and giving you what we refer to as an E-jit. So now I'm going to find my tip again. There's a star pattern and it ends, and you can actually see that it's already glue shot. You can see the glue within the vein there, and that's how I make sure. I still put pressure for this time just to make sure, and I depress, hold for 4 to 5 seconds, and now we pull back 3 centimeters and hold, and we do this for 30 seconds. And you would just repeat this over and over until we get to the 5 centimeter mark. So we're good for 30 seconds there. And I'm not sure whether this would capture in here. I'm going to bring the gun near the microphone here, and I'm going to depress 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, and click. That click is critical, okay? That's what charges it again. Now I'm going to do it again. And click. If you don't hear that click, you should just gently press on the back of this until you hear the click happen. And here's my last segment, and that puts me at 5, 4, and I'm going to just stop right there, and I'm going to hold there. So we're at the pretty much 4 centimeter mark right of the sheath here. You really just want to stop right there, 5, 4 max, much. And I'll show you why in just a second here as we let this set for the final part. You have your 7 French introducer sheath here. And now, as we finish, what I'm going to do is I'm going to keep that sheath there. I'm going to bring this out, and I'm going to then remove the sheath, okay? So what that does, it prevents any little glue cast that might have been at the tip of this, and you see a little bit still left in there, from coming out of the vessel. It just really stays in the 7 French introducer. And we're done. All right, that's a wrap. Key things about this, all right, a few pointers. You can do this over a bare sheath. You can access the vessel with a 16 gauge, and you can put your guide wire through the 16 gauge and then put your introducer. Okay, that's number one, rather than doing the 7 sheath. That's a step. As I mentioned in the video briefly, you can skip the wire. I skipped the wire many times. It just really saves you an additional step and some time. Most of these great saphenous veins and small saphenous veins are straight enough and thick enough that you just guide with that dilator and introducer sheath without any problems. Please make sure that that junction, you stay safely away from it. Okay. I like to see closure, as I mentioned, as I go, making sure that I have closed. Some of these vessels can get pretty large. You might want to provide more than one depression. Each depression, by the way, is 0.1 cc's of glue. All right. So you can actually calculate how much glue you have given, and you want to know that at the end. Finally, that click, as I mentioned, is key. It's just a ratcheting effect. If you have been using VenaSeal already, you've been contacted by Medtronic to make you aware of this. If you have not used it, just be aware that there have been some times in which you just might not click. It's just a simple depression in the back. You'll hear it and just re-engage the mechanism inside. That's what guarantees that you're going to deliver with each segment the appropriate amount of glue, that 0.1 cc. You heard me mentioning under the Medtronic guidelines, an FDA approval is 3 seconds per depression. I like to do 4 to 5. I found that there's still glue being delivered. I'm given the maximum amount of glue per segment. It should be every depression is 3 centimeters, and you do 1 second. There are variations of this. These are sort of obviously physician provider dependent. I like to do 6 to 9 centimeter segments, each 3 centimeters with a 0.1 cc. So we'll have more time to discuss second, and let's move on.
So a quick review with on Varithena, 1% polydocanol with a 65 to 35% ratio of carbon dioxide to oxygen and a 0.8% nitrogen ratio. The canisters, once activated, there's about 45 mLs of usable foam. This foam is drawn up in a silicone-free syringe. I usually draw it up in small aliquots, depending on how much I'm estimating I'm going to need to do the job. And then once you draw the foam up into the syringe, you have about 75 seconds before some of that foam starts to break down. So you want to inject it within approximately about a minute. Total amount of safe Varithena that can be injected at any one time would be about 15 cc's of foam. So these tributaries are branching and tortuous. So it's difficult to access them with a micro introducer. So what I'm using in these videos is a 25 gauge butterfly. And then we're injecting straight through with that butterfly. Obviously, you want to be able to visualize the needle tips so you know you're in the correct vein. A few other things that you'll notice is the patient's limb is going to be marked. We usually mark the disease tributary with like an X, and then we look along that path of the vein and we identify any perforators. And these perforators are marked with a line. This becomes important because as the foam starts reaching the perforator, we can put some digital pressure on that perforator and prevent injection into the perforator vein. After we mark the limb, you're going to see we're going to elevate the patient. So either I'll use Trendelenburg positioning or I'll use the wedge that you'll see in order to drain the vein. This allows us to use the minimal amount of effective sclerosant to do the job. This will minimize our risk for DVT. It also allows us to control the injection a little bit easier. And then lastly, it helps prevent thrombophlebitis afterwards. After we're done the injection, we'll go ahead and do some dorsiflexion, just again, to try to prevent any deeper clots, and immediately wrap the leg. I typically don't use the padding that comes with the Varithena kit when I'm doing these tributaries, because a lot of times I'm covering a lot of different areas. So we'll just use some 4x4 gauze and an ACE wrap. They'll keep this ACE wrap on when I'm doing tributary disease. I tell them to just keep it on for 24 hours rather than 48 hours that many people recommend when they're doing larger caliber veins like the GSV or the SSV. And then they'll go back to their stocking use after 24 hours during the days only. And I usually emphasize that these stockings should be worn for at least a week. I let them know that the stockings can help the veins close, and the stockings also help minimize some inflammation when those veins close. If the patients don't want to wear the stockings for that long, I have had patients only wear them for a few days. The vein still ends up closing, but sometimes the vein closes in 4 to 6 weeks and they have some delayed swelling. So, if you just let your patients know that with any of these injections, it's a reaction that ensues, and it takes some time for the veins to close. And it's when the vein closes that these patients are going to get that inflammatory response. And so some delayed achiness, swelling, even into the foot and ankle, is normal with injecting these tributaries. So let's go ahead and start the video. I'm just going to skip right to the videos. There we go. So again, we're going to mark the limb, and we're going to mark the tributary that we're going to be injecting. And then we'll follow the course of that tributary proximally. And this allows us to identify any perforator veins. And we'll mark the perforator as well. So this disease tributary went from the ankle up to the knee. And then we're going to elevate the limb so we can drain the vein. And you can use Trendelenburg positioning, or in this case, we're using the wedge. And then we've activated the Varithena canister. We've purged 1 cc, and now we're going to draw up a couple cc's for this injection. Once the canister is activated, shelf life is 30 days. And then this is a 25 gauge butterfly. And with Varithena, I typically inject distally and move more proximal. With foam, I find that it flows proximal and distally pretty easily. With the Varithena, it doesn't flow distally as well. So I start distally and we move more proximal. Again, small, quick injections, maybe 1 cc there. And then we'll go above the perforator. We're putting pressure on that perforator. And then we'll do another injection. Just visualize the needle tip, get a good flash, and then go ahead and do an injection here. And then we'll follow this again, more proximal. See, it fills all the veins that we want to target. And then again, we'll use some 4x4 padding and an ACE wrap. And we want them to resume ambulation as soon as possible. We're all getting a lesson in how to wrap a leg. So. All right. Second video here. So again, the leg's been marked. We've elevated the limb, again, using a 25 gauge butterfly. You can see the monitor there. We've got a good flash, and we're going to inject. And again, putting some manual pressure over the perforator site. And again, Just injecting above and below the perforator. And just making sure it fills the vein. And you see that went right down into the greater saphenous vein. All right, so now we move on to from treating tributary disease to treating perforator disease. And perforators are a common cause of recurrent superficial venous disease, obviously. They can also cause some focal pain, swelling, as well as ulcerations. In the setting of a venous ulcer or a healed ulcer, a pathological perforator is defined as a perforator with a diameter of at least 3.5 millimeters with a reflux time of 0.5 seconds or greater. Indications for treatment, obviously ulcers or focal pain, swelling. A lot of posterior and lateral varicosities can be fed from a disease perforator. And again, caution, both nerves and arteries run with perforators, so we need to pay particular attention to that. When it comes to closing perforators, we can use thermal modalities as well as chemical modalities due to the pinpoint nature that is required in order to get into the perforators with either a laser fiber or an RFS stylet. Closure rates tend to be a little lower with thermal modalities. And then, so we're going to first show a laser ablation of a perforator. So we're identifying the perforator. Oops, I'm sorry. Let me go back. There you go. We should start in a second here. So we're going to use some topical anesthesia, and then we're going to use a 16 gauge. If you guys can play it from the back, that would be helpful. We're going to use a 16 gauge needle to access the vein. In this instance, you'll see the perforator is here, but it's feeding into a dilated tributary vein. So the goal here is to cannulate it from the right side, put the laser fiber through, and actually close the tributary, which will seal the perforator as well. We're removing the 16 gauge needle. Now our laser fiber is in the tributary. We're going to mess around the fiber. And then we go apply heat. This is a 1470 laser fiber. And you'll see the steam bubbles, and we'll pull back and make sure that whole tributary is treated. And then once you can see it kind of pop out of the vein right there, then you can stop applying heat. This is a perforator that's being treated with an RFS catheter. And in this case, again, we'll numb the skin. I use a 16 gauge needle to make a track through the skin into the perforator. This perforator is a posterior thigh perforator that was feeding varicosities that run medially. So after we treat the perforator, you'll see I'll do a foam injection into those varicosities. Again, anesthetize the skin. You can see the perforator vessel there on the ultrasound. And I try to anesthetize along the track as well, just to make it as comfortable as possible. The RFS stylet sometimes can get some resistance while you're pushing it through the subdermal tissue. In this, we're going to make a track into the perforator with a 16 gauge needle. And then through that puncture site, we'll place the RFS catheter. And if you look, you'll see the monitor here, and you'll watch the placement. That's the tip of the RFS catheter. And then once we're in the perforator, on our RFS machine, we'll see the ohms drop down to 400 or less to confirm that we're in the intravascular space. We take out the trocar and then do some tumescent around the catheter and vein. This also helps collapse that perforator onto the catheter. And depending on the size of the perforator really determines how long I apply heat. For large perforators, you want to try to apply heat to all 4 quadrants of that perforator vessel for about a minute each, so a total of 4 minutes. Some smaller perforators I may close for 60 seconds or 90 seconds. You'll see also that I'll try to change the angle of the catheter here. And that helps try to get all 4 quadrants. But I feel if you tumescent it down, then it makes good contact. And you can see the steam bubbles on the monitor there. And again, changing angles, trying to get all 4 quadrants of the perforator vein. At this point, you're just having some lovely conversation with the patient about the weather or something. Now you can see this perforator, like I said, it fed some varicose veins that ran up the medial aspect of the thigh. So after we closed the perforator vein, just to be thorough, I just injected into the varicosities as well. And again, we're using 0.5% STS, 3-to-1 ratio with carbon dioxide through a 27 gauge butterfly. And we're watching it travel right in through those varicosities. And then lastly, we're going to show one more video, and this is using ultrasound guided foam sclerotherapy. The interesting thing about this is this patient had 2 perforators in close proximity to each other. So this is why we chose to use foam, because we can, with one injection, we can treat both of those perforators. So you can see these perforators were feeding into tributaries, and there's the 2. So we're just going to inject into the diseased tributary and watch the foam flow down into the perforator. Once it reaches the perforator, we'll stop injecting. So again, using the Tessari method, 20 cycles. And this was 0.5% STS with 3 cc's of CO2. And then just inject and get a good flash. Of course, visualize the needle tip. And then once you get a good flash, you can go ahead and inject. And then I want my vascular tech to follow it, the foam proximal, until it dips down and fills the perforator. There you go. You can see it fill into the perforator there. And obviously do some dorsiflexion. So you dilute any sclerosant that enters the deep system. And then we'll wrap them up just like we wrapped the patient up for the Varithena. So, thank you, guys. Appreciate it. No. So the next speaker again is Dr. Eddie Fernandez is going to speak on the pathophysiology of lymphedema.
Okay, thank you so much, everybody, again. Thanks to, by the way, to the hotel for giving me water that does not expire until 2024. Very interesting that water has expiration dates. I'm here to talk to you about pathophysiology of lymphedema. So I'm hoping that you all stay awake for this, as to say. But I'm hoping to challenge how you think about lymphedema, how you see lymphedema, how you approach lymphedema with your patients. So when we think about lymphedema, we traditionally say, hey, this is just chronic. It is a progressive condition. We all know this is caused by failure of your lymphatic system to adequately receive and transport lymph fluid, or their lymph load, as it's referred, back into the cardiovascular circulation. Okay, it's excessive protein-rich fluid that then accumulates in these interstitial spaces and leads to tissue changes and impaired immune function. And this lymphatic failures can sort of be categorized in three different fashions. Okay, number one is a dynamic insufficiency, or the increased lymphatic load on the healthy lymphatic system. Okay, so too much fluid for a healthy lymphatic system to actually mobilize appropriately. Congestive heart failure, early stages of chronic venous insufficiency, pelvic venous congestion. Number two is a mechanical insufficiency, a normal amount of fluid, but an impaired transport mechanism. So usually this is the congenital patients, those early infants that are born with the lymphedema, the teenage patients that develop lymphedema in a limb, and those unfortunate cancer patients that we see so frequently that have had lymph node resections, okay? Not just the breast cancer, but also we cannot forget about our GI pelvic malignancies. This is something that we do see frequently and unfortunately don't provide proper education. And then there's that combined insufficiency. So you have both sides. You have the dynamic and you have the mechanical, classic fleval lymphedema, in which your venous system is promoting increased lymph node load, and the lymph system is now also impaired and damaged, and it cannot move that lymph load out of place. And when we think about the lymphatic system, I love this. And the problem is, search for the lymphatic system, and you get hundreds of images of great green guys traveling all over your body, but you never see a good image of it combined with the rest of the vascular system. We should be thinking about this as one system: your arterial, your venous, and your lymphatic together. They are a network, okay? And the lymphatic system, though, has its own network, just like we refer to our arteries, arterioles, and capillaries, and we have veins, venules, and capillaries. They also have vessels, nodes, and they're involved in this nice balance of fluid absorption, transport of fats, and immunological function. And they span the entire system. So obviously, the combining and getting that image of your pipe system at home, you would not think of your water coming in without your sewage coming out, all right? And that nice anatomy is really no different. You have your lymph capillaries that transport, are in charge of the absorption of all that lymph load or lymphatic fluid. And they move it through the vessels and to the lymph nodes and through all the way through the lymphatic ducts that finally move it back into the circulatory system. So it's a nice movement of fluid throughout this. And that movement of fluid is really simplistic. We talk about veins a lot. We talk about the failure of these valves. And in many ways, the lymphatic system, nature did not reinvent the wheel. And it uses the same valvular system to move lymph through these valves through intrinsic contractility of the lymph vessel walls, muscle activity, respiratory movement, and arterial pulsation. And it all really comes to that capillary, right? When we are thinking about venous insufficiency and where the pathology happens, is sort of that excess venous stasis, a venous hypertensive state that happens at the capillary level. Well, same with the lymphatic system at the capillary level. Okay, this capillary system each have little surrounding dendrites that help with the mobilization of that fluid from the interstitial space into the capillary system. And then these filaments allow the fluid and propel it. Okay, and the valves, and you look at under electron microscopy, just really just nice, simple valves that are working the same way as the venous system. And it is here that it can break down. And these capillary systems, just as very small micro vessels, are very sensitive to the environment around them. So under normal conditions, they're functioning just appropriately. But as we start to develop inflammatory process and you develop monocytes transforming into macrophages to address increased lymph load and mobilize some of these proteins and creating some of the damaging cytokines, this lymphatic capillary system starts to break down. And as it breaks down, you then get aggravated inflammation, you get increased edema because the inability to mobilize that lymph load. Okay, you get increased epidermal thickening, more inflammatory changes progressing, and decreased range. So it's just sort of a bad system. And it's the job of our lymphedema therapists to help reverse this. But it's also our job as phlebologists to make sure that we are addressing what might be some of the culprits, whether that is pelvic venous congestion, chronic venous insufficiency. We owe it to this patients. And this is something why the American Venous and Lymphatic Society is now named that. This is all combined and we owe it. Now, this is it. This is pathology of lymphedema, right? This is how we know it. But we're going to make it harder and sweeter for you, okay? Because this is where it really has started to change. It's about the endothelial glycocalyx layer, the nice sugar and shell layer that not until the invent of electron microscopy in the mid-1900s, sound weird, mid-1900s, it's like, it makes me feel so old sometimes that I was born at that time. But that we are able to really identify this gel-like matrix, okay? They're hair-like projections that extend into the lumen of blood vessels. And they are key in the regulation of fluid and macromolecule movements in and out of these vessels. And in recent times, Levick is able to demonstrate that there's really no net capillary reabsorption as we thought, only a diminishing net filtration out of the capillary bed, okay? So, and even under extreme duress of hemorrhage and hypovolemia, it's only able to mobilize about 500 cc's back into circulation through reabsorption of our capillary. So where is this going? This is really going through the lymphatic system. So this dynamic tissue that in response also to the stimulus of inflammation, ischemia, sepsis, trauma, diabetes, intravenous fluid mismanagement, and it starts breaking down. And when it breaks down, then it sheds and it allows further fluid to escape. And that fluid inability to come back into the circulation increases the lymph load. And our lymphatic system starts getting overwhelmed and starts to break down. So something that from the late 1800s has been dogma of medicine, of the Starling principle of microvascular fluid exchange. And we understand that with increased oncotic pressure or increased static pressure, you get this shift supposedly back into the capillary system, venial system, and uptake it back, and that the lymphatic system was really only in charge about 10% reabsorption. This is really no longer the mainstay of thinking. And the new revised Starling principle really demonstrates that this reabsorption is not really happening because of that glycocalyx layer. And it is really up to the lymphatic to uptake pretty much 90%, 100% of that fluid, okay? So the lymphatics, not the veins, are primarily responsible for tissue fluid balance by absorption, reabsorbing that interstitial fluid or lymph load, okay? So we can now start to think that all chronic edema indicates an inadequacy and failure of lymph drainage. And this is really the paradigm that I leave you with. We need to redefine how we think lymphedema. We need to really start to think that when we used to think of the prevalence of lymphedema worldwide, whether it was related to filariasis, cancer, chronic venous insufficiency, it might be more propensous because we start to have to think about all forms of edema as some form of dysfunction of that lymphatic system. And early on, you have that edema. You can think of it as abnormal excess accumulation of serous fluid in connective tissue. And the lymphatic system is temporarily overwhelmed and not permanently damaged, versus sort of the more classic in which you have a heavy proteinaceous accumulation of fluid because of damage. So, but they're both lymphedema, and this is lymphedema. It's just a spectrum of edema. It's not just your buffalo hump, your patients with disfigurement or fibrosis. So I thank you for your time, and we'll have Dr. Theresa Soto to continue the lymphedema talk.
All right, so yes, more on lymphedema, and Dr. Fernandez and my topics overlap quite a bit. In the multidisciplinary approach to lymphedema, what I'm talking about more is what our responsibility is to our patients for lymphedema care. And Eddie, having seen my slides, has stolen a couple of my lines, which is fine because we're sharing. This is how we learn. But all chronic edema is lymphedema for all of the reasons that Eddie just said. And it is incredible how many people have swelling, have lymphedema, how many people it affects, and how little we really know about how to take care of it. And we don't really have a good evidence-based sense of what to do for these patients. As Eddie said, the American College of Phlebology is now the American Vein and Lymphatic Society. It means that we are in the right space to take care of these patients. So on how you go about taking care of these folks, you need all of your community physicians to help you take care of every aspect of these patients. Primarily your lymphedema therapist to get the whole process of the limb looking better and feeling better. But you need to involve your primary cares, your podiatrist, your dermatologist, wound care, orthopedics, some psychological care or community support, home care. We need to get them from this acute phase of getting their legs working a bit better to a maintenance phase where they can actually do a lot of this in their own homes with their own families and their support. We are always there as part of this underlying support system. Our lymphedema surgeons come in there for those folks who are appropriate as well. So the management of lymphedema has to be a very holistic approach to care. It is not just give them a lymphedema referral, say, here, you need some compression stockings, tell me how it works out. You have to dedicate yourself to the care of these patients because you really have to get them engaged and on board with their care. These calf muscles would be fantastic to see in our clinics, but we don't see these kind of legs in our clinic. We have the folks that shuffle in, slide in, don't get up, don't move. They don't have much of their calf muscle or foot pump left, and they actually end up with a lot of swelling because the function is missing. So when you work with a lot of older folks as well, believe it or not, there's more age-related and senescent or senile lymphedema from just not getting up, moving, the system aging, and being a little bit less invested in their care and their mobility, or being afraid of being mobile, falling down, hurting themselves. So there's a lot of psychology and just social need for a lot of these folks. We have to remember as vein specialists that we are in the right space to see these folks. A lot of times somebody will come in with very swollen legs, and the first thing our vascular tech does is look at them and go, wow, Okay. Try to imagine how to get their hand around or get the pump around to squeeze those legs and compress those legs, and then ask us, how much do I have to scan? How much do we have to see here? Well, there are so many people who have venous disease who also have lymphedema. So we actually have to sort out who has lymphedema and who has phlebolymphodema, who has venous disease, who has superinguinal venous disease. Dr. Raju told us, you got to look up higher. You got to look for the iliac vein disease, and you have to treat that. If we can treat vein disease, we can often take a lot of their swelling down if their function is still pretty good in their lymphatic system underneath. Primary cares, we have to talk to our primary cares when we go out and tell them this is what lymphedema is and this is what you can do to at least get it started. Don't just hand out diuretics and say, oh, it's swelling, here you go. These guys are in the prime spot to talk to them about their entire well-being. Do you get up? Do you walk? Do you move? What are you eating? What is your weight? Your body mass index is high. Do you elevate your legs? We talk about compression stockings. And then look at their medications. Some folks come in on so many medications that you can't even try to put together interactions. And so if you can have them work with their primary care on what medications they really need, you might find that you can cut down on some of the swelling just because of what they're doing or not doing. So the other thing to tell your primary care is if you've done compression socks and you've done diuretics and you just don't know what to do with folks with swelling, send them to us because we'll start to sort it out. Don't just send them home and say, well, you have swelling. Our lymphedema specialist, you need a certified lymphedema specialist. Like I said last night, this is not massage envy, dual lymphatic massage. Those work because you can just stimulate a little bit of lymphatic drainage and make somebody feel better. But the minute they stand up, the swelling starts to come back because they're not followed up with the bandaging, the wrapping, the education, the calf muscle exercise, the home exercise program. These lymphedema therapists, when you find that perfect certified lymphedema therapist in your community, they love lymphedema. They love the results that they can get for patients. They get them up, they get them moving, they get their calf muscles working at home, they get the bandaging, the wrapping, they get the family engaged. They also are folks that I will refer to for the whole physical therapy part of it. You can't take somebody who's not really ambulatory or who's walking with a walker and their balance is something that scares them, or they have so much swelling that they can't really feel the floor, and not get them physical therapy. And this is what benefits that lymphedema therapist as well. If you have a combined lymphedema therapist, physical therapist, because they can get the whole program going. They get them up, they get them walking, they get them more mobile. And every time they come in for physical therapy, where's your compression? Where's your stockings? Are you using your pump? So they keep backing up what they've been telling the patients to do to take care of themselves. I get my pneumatic pump liaisons to go into the lymphedema therapist's office. My lymphedema therapists know about the pump. They've learned about the pump. They know the reps. They know who they can call. They know the problems with the pumps. Patients meet the rep in the lymphedema therapist's office. So it's not a matter of that liaison trying to get to their house and it being COVID and not being comfortable. They're there. They get their demo there. The doctor has told them this is good for you. The lymphedema therapist has told them this is good for you. The pump liaison's there to help them, is telling them it's good for them. So this is something that really reinforces their need to participate in their care. Certified lymphedema therapist, lots and lots of different certifications. Go to your lymphedema therapist's office and look at who they are, what they're doing, what the patients look like, what their program looks like, what results do they get? Do they follow patients up? What certification do they have? Know who you're sending to. Weight management is a huge topic. We could talk about that for a long time. We have an era of really, really solidly large people. And this chronic obesity related lymphedema it's a difficult thing to manage because there's a lot that goes on when folks are getting up above a BMI of 30. There's a lot of societal and psychological and chronic problems that come with being that overweight. This is a problem where you have either decreased mobility of fluid because you've got a large pannus sitting there. Adipose tissue is a secreting tissue, so you get a lot of fluid from adipose tissue. You're overwhelming the system. You've got inflammation from edema, And these folks who are much bigger don't get up, don't move. They don't lay down to sleep. They sit in chairs, their legs are down, they can't elevate. They can't get compression on because they can't see their feet or bend. They're not mobile. They can't even get enough flexibility to get a stocking on. So this is something where weight management makes a difference. And this is something that is a serious conversation that we have to have with our patients if their primary care has not. Dr. Green looked at some patients in 2012, and what he found is in patients who had no real risk factors outside of their weight for lymphedema, he did lymphoscintigrams. And what he found is that the lymphoscintigrams were positive when he got up above a BMI of 56, 57. So he was using a cutoff of a BMI of about 60. And they thought, well, if these folks are positive with a BMI over 60, what happens if we help them lose weight? And will reducing your BMI make your lymphedema go away? Not always, not necessarily. But what we have to look at is that gap between a BMI of 30-ish and a BMI of 60-ish. And if we can get through to the folks who are in the 30, 35, heading to 40s and say, look, this is a lot of what you can do for yourself. There's no easy button for this. If you can reduce your weight and not get to a BMI of 60, we're going to have a lot better management of your swelling. And quite honestly, it's good for their heart, their joints, and their self, their sense of self and how good they can feel about themselves. If they can take charge of this and they can start losing weight, you can get compression stockings on if you can bend over and get to your feet. You can elevate your legs if you don't get short of breath when you lay down. So there's a lot just outside of what the adipose tissue does to your lymphatic system for us to help our patients with who are obese. We need our dermatologists because there are skin lesions that are more than just rubor from lymphedema. You never want to miss a lymphangiosarcoma, a basal cell, a sebaceous cell carcinoma, a Hodgkin's type tumor. So when you're looking over your patient's legs, look for potential issues, problems, work with a dermatologist who knows what you're looking for. Our podiatrist, I recommend to all of my patients seeing the podiatrist at least twice a year. Don't wear flip-flops, don't go outside walking around barefoot, because if they get a skin infection and it gets into their foot, it gets into their leg, it's a mess to try to treat. And it really, it can be avoided. And if you work with a podiatrist who understands what you're looking for these folks, nail care so they don't get infections in a nail salon, looking for fungal infections, making sure that they actually can stand on their feet properly, that they have good stance, they don't evert or invert, and that they're actually walking properly, because those calf muscles are needed for walking properly. So that heel toe motion is actually important to keep the calf muscle pump going. For orthos, you want to make sure that if your patient has had a joint replacement or they're not walking properly because they have a varus malformation or a valgus malformation, or they have something that's impairing the way that they're walking. Maybe they have a spur in their foot or something, they have pain, so they're walking on it funny. Look at how your patients walk, look at how they stand. And if they have something potentially orthopedic going on, send them to your ortho, have them take a look. Maybe we can work together and get them walking better. But I also encourage my orthos to talk to their patients about the kind of swelling they're going to have after their joint replacements. Lymphedema surgeon has to be in your wheelhouse as well. You have to have somebody to refer to when they've done all of this stuff and it's just not working, it's just not getting the job done, or in somebody who has real primary lymphedema who you may want to send to for a bypass. And these folks are very few and far between. They're very specialized. You want somebody who actually does these kind of procedures regularly. And one of the last things I'll leave you with is that a lot of this lymphedema literature, the stuff that's out there, is based on folks who have cancer and breast cancer. And while these breast cancer patients are very important and they've at least started the conversation on lymphedema, we need more work done on just lymphedema in the lower extremities, because these folks are debilitated and they're unhappy. They stay home. They don't take care of themselves. The families don't know what to do. They can't go out, COVID or not, because they drip fluid on the floor, or they can't get into their car because their legs are so heavy. So we have to work a lot more to get better research and better studies and know much better what we can do for these folks, have a much better plan of action. And then what I'd emphasize to everybody is build a team, know your team, talk to them, tell your dermatologist what you expect, tell your podiatrist what you expect. They'll send you, you'll send them, and let your patients know that they're important. So they have to be engaged. They have to be part of it. A lot of it is what they do for themselves, but you have to follow them to know, are they using their compression? Are they getting out walking? When they come back to the office 3 or 6 months later and say, oh my gosh, I lost 20 pounds and I can get my, my shoes on or something, you have to be positive, and that's encouraging. And if you're following them up and their primary is following them up, the lymphedema therapist is following them up, the pneumatic pump folks are following up, to them, it says that they're important to somebody and it matters. And it's the best thing you can do for somebody to make them feel like this is something that can be managed and you care enough to help them out. So thank you.